So thank you everyone for joining us this evening. My name is Kyle Boudreaux. I'm with Medtronic, and together in partnership with Dr. Roth at Southern Urology in Lafayette, Louisiana, I'm happy to bring an educational event to you where you are at your house or work or wherever you may be at this time. Tonight, Dr. Roth is going to discuss the disease state of overactive bladder and some treatment options, and wanted to go through a few housekeeping items with you to start. So at the bottom of your screen, you may note there's a Q&A section. If you have any questions during the course of this event this evening, please submit those through the Q&A, and Dr. Roth would be happy to answer those questions for you. Also, all lines are muted, and so if you do have a question or have a item you'd like to be addressed, please post that on the question and answer section. Upon completion of this event, you'll receive a survey. If you could, please help us to improve future events by completing this survey and submitting it. That'll help to better refine the events that we bring to patients out there. I'd like to introduce Dr. Roth to you. Dr. Roth is a urologist who practices in Lafayette, Louisiana. Originally, he was born and raised in Baton Rouge, Louisiana. Started practice close to 20 years ago. He initially trained at Louisiana State University in New Orleans, and then moved to Texas to train at the University of Galveston for his urology residency. Upon completion, Dr. Roth moved back to Southwest Louisiana to begin his practice. He's very involved in several medical societies, including the Louisiana State Medical Society, Society of Urology Prosthetic Surgeons, and the Louisiana Medical Political Action Committee. Dr. Roth is married. He has 3 beautiful children. He is a very avid outdoorsman, loves LSU football, big tailgater, and #1 dad. He has a special interest in helping individuals with urinary function matters such as overactive bladder and urge incontinence. And tonight he's going to spend a little time to kind of review this particular set of symptoms and disease states and treatment options for you. And without further ado, I would like to introduce to you Dr. Brad Roth. Dr. Roth, could you go ahead and share your screen? Take the ball.
We're having trouble with the video. It says that you
Okay, let me see if I can figure out a fix for it.
the host has stopped it.
There you go. Try that.
All right. Thank you. Says I'm Debbie Ryan, but we can get past that. That's good.
I'm going to go ahead and mute my line. Thank you.
Okay. Yeah. Thank y'all. Tonight we thank you, Kyle, for that introduction. We're going to spend a few minutes. I think we can get through this in 20 minutes. We're going to talk about, I just want an overview of kind of overactive bladder, some of the things that are causing it, and some exciting ways we have to treat it. It's a very common problem. And we have a slide deck here. I'm going to flip through the slides. I'm not going to go over the slides verbatim. I think that's boring, but we'll just kind of touch on a few points. So thank you for spending time with me right here before Christmas. I know y'all have things to do, but let's get started. And hopefully you'll learn some things. Please feel free to submit any questions you have, and I'll be happy to answer them. Let's see if I can get.
Okay, if we share the screen.
All right. Here we go. Here we go.
But it's not changing. Kyle, it's not letting us share the screen or go through the slides.
Okay. All right. Here we go. So, as I said, incontinence is a very common problem. And surprisingly, over half of the people that have it don't really discuss it with their doctors. And I think majority of people feel like, well, this is a part of aging. This is, maybe it's a phase I'm going through. So they just, you're talking about people feel like, well, high blood pressure, my diabetes and heart problems and peripheral vascular stuff is all more important. This is not really that important, but you have to mention it to your doctor so that we can address it. And certainly it is eroding to your quality of life, these issues. It starts to control your life. So tonight, I just want to talk about understanding bowel and bladder control. We'll talk about the pathway for this condition, treatment options, and we'll have an opportunity to ask some questions. So when we talk about overactive bladder, and that's encompasses urinary frequency, urgency, and urge incontinence. We're talking about over 37 million Americans. That's 1 in 6 adults. And fecal incontinence is still as not a big a problem, but probably bigger than you would think. And this is, people even talk less about fecal incontinence because they feel like this is embarrassing and they're afraid to bring this up. And but we have treatment options available for that too. So what isn't normal about bladder control? Certainly having accidents is not normal. Having that urgency, like you have to go now, is not normal. When you start to plan your life and activities around the bathroom, this is not something that, is socially desirable. When you're having to monitor how much you eat or drink because you're trying to control things, is certainly not a fun way to live, and certainly not any fun to use pads or protective garments. When you look at how the bladder is controlled, it's a combination of communication between the brain and the spinal cord and the urinary tract system. So I'm going to simplify this. And what I want you to understand is that as the bladder is filling with urine, there's signals that go to the brain that tell it, hey, my bladder is full. The brain sends signals back to the bladder to tell it, I want it to contract and I want the sphincter muscle to relax so that the bladder opens and you can urinate. So then in a normal system, your bladder fills urine to its capacity. When it gets to its capacity, it sends a signal to the brain. Brain sends a signal back to the bladder saying, okay, I want to be empty, and it contracts. And when the bladder contracts, the external sphincter releases, and you have a normal urinating process. So any breakdown in this system, when you have urgency and constantly feeling like you need to go and going before you get to the bathroom, there's a breakdown in this system. It's the same is true of the bowel. So as your food is processed and the waste comes through the colon, comes down here in the rectum, you've got sensory nerves down here, which again, as the bladder, just like as the bowel gets full, just like the bladder, those signals communicate to the brain to tell, hey, my rectum is full. Brain sends a signal back to the rectum. We want the rectum muscle to contract, and then you have a bowel movement. So that system is similar for both the bowel and the bladder. And without getting any detail, that's basically, in very simple terms, how things work. The causes of incontinence, we don't talk a lot about this, but our daily habits, most people, when they wake up in the morning, I'm not one of these. I don't drink coffee in the morning, but my wife does. Certainly, I would say probably the majority of Americans get up. Coffee is kind of a way to start your day. And that is great. You get a dose of caffeine, it wakes you up, but it also inhibits antidiuretic hormones. So you're going to urinate more. We all know that if we drink coffee, we're going to urinate. So if you're having problems with your bladder and overactivity and frequency and urgency, if you're drinking 4 or 5 cups of coffee, you're certainly not helping yourself. So it's not that coffee causes incontinence, but it exacerbates any urinary issues you're having. That's true of a lot of fluids. I mean, we all know if you have overactive bladder problems, frequency, urgency, you've already limited the amount of fluids you eat or you drink during the day. You stop drinking certain fluids by the afternoon because you don't want to be up all night. So you've already done that. So again, it doesn't cause incontinence. It doesn't cause that dysfunction, but it does exacerbate it. Certain medications and supplements you take, the more common ones are diuretic medicines that we use to treat volume overload, high blood pressure, makes the kidneys get more rid of more fluids. It's going to make you urinate more. So that could cause issues because you're making so much more urine. If you use to a normal capacity, all of a sudden your bladder fills up very quickly. You're going to have to go quickly. Reduced physical mobility can cause problems. You know, you see someone who's had a stroke, who's walking with a walker or a cane or perhaps in a wheelchair. You know, you get the urge to go. It's taking you longer to get to the bathroom where, you know, as before you didn't have a problem. Maybe now you do from your just mobility issues. Pregnancy and childbirth is among the most common cause of stress incontinence. We'll talk about that. Irradiation to the pelvis causes fibrosis to the bladder wall, so it makes the bladder wall functionally smaller. So if your bladder can't hold a normal capacity, it gets stiff and you have to all of a sudden go at much smaller capacities. Any pelvic floor injuries can cause urinary issues. The 3 most common bladder control problems involve stress incontinence, urinary retention, and overactive bladder. Stress incontinence is leaking urine when you cough, laugh, sneeze, lift up something, bend over to pick up something, tie a shoe, trying to exercise, jumping around, anything that causes stress on the bladder with resultant leak is what we call stress incontinence. This is more common in females from childbirth. Any guy who's had, for instance, prostate surgery for cancer can get stress incontinence. Very, very common in women, more so in women than men. Urinary retention is a condition where the bladder doesn't empty completely. So if you think about constantly feeling the urge to go to the bathroom or going to the bathroom frequently or going a lot at night, this can be from overactive bladder or failure of the bladder to empty. Both of those conditions gives the same symptoms. So if your bladder doesn't empty all the way, if it's filling, you go to the bathroom and it's still half full, in a very short period of time, it's going to be full again. So you're constantly gotta go, because it never empties. So, you know, sometimes retention can be sensed by a patient. A patient knows they're not emptying because they still feel full. They don't get that sense of relief after urinating. And sometimes people can't tell that they're in retention. They go to the bathroom, they feel like they're empty. They're constantly, you know, 15 minutes later, they have to go again, but when they actually go, they feel empty. And if this happens over a long period of time, a person may not be able to tell that their bladder is not emptying. And that's very easy to measure. This can be associated with a weak stream or dribbling, and possibly even with the need to use a catheter. Overactive bladder is when you have those symptoms of frequency and urgency. You're constantly needing to go day or night. Some people have more problems at night. Sometimes people have more problems during the day. Sometimes it's both. But that's when that system is broken down between the signal going from the bladder to the brain and back from the brain to the bladder. And the bladder is just being overstimulated and you're constantly feeling like you need to go. So again, overactive bladder, urinary retention, As far as you're concerned, the symptoms are the same. You have to go a lot, and there's some differences in the way we treat, but we're going to talk about one way that we can actually treat both of those. Fecal incontinence is obviously when you have a bowel movement before you can get to the restroom, and that's if you had to, quantify which is worse, fecal incontinence, urinary incontinence. I think most people would say urinary incontinence. Obviously, we're here to help with both. Fecal incontinence isn't as common as urinary incontinence, but there are treatments for that, which we'll get into as well. So let's talk about treatments. Again, these are all geared around getting you back to a normal life. It's all about, as we age, our quality of life is so important. And incontinence is not a life-threatening problem, but when it starts to erode your quality of life and you can't enjoy the things that you used to enjoy, and you're avoiding things that you like to do out of fear that you're going to wet yourself, those things come into play. When we talk about treating incontinence, overactive bladder and fecal incontinence, we have to look at several things. First of all, we have to have the right diagnosis. That's very important, and that's why you need to, when you come in, mention it to your physician so that we can start the process. Frequency, urgency, urgent incontinence can come from a urinary tract infection. That's always the first thing that we look at. Bladder stones, urethral strictures, all these things can cause incontinence and bladder problems. And, that's all treated differently. So we have to have the right diagnosis. The first steps are always if we can do any kind of dietary changes. I was getting at, coffee, iced tea, if you're drinking lots of fluids, alcohol is another one that's going to, again, not cause those problems, but if you do have any bladder problems, it just exacerbates that. So by the time we see people and have conversations about this, most people at home have already tried to limit the fluids, and maybe they don't know about coffee and alcohol, but most people are, and they've already done that. Exercise and physical therapy. We have physical therapists who we can set patients up appointments with to try and strengthen the pelvic floor. So all these are obviously things that we can do without prescription medications and procedures and surgery. So these are always our first line: dietary changes, physical therapy. Moving on, when those fail, we move into oral medications. There are lots of different medications we can use for urinary frequency, urgency, and incontinence. Many of you may have tried some of these medicines, maybe not. If you've tried them, the more common ones have all had similar side effects, which include dry mouth, blurry vision, constipation. There are some newer ones out that can cause high blood pressure. The classic overactive bladder medications have all caused dry mouth and constipation. Of course, everybody hates that. So even if you're doing better, but we fixed one thing and caused another one, a lot of people stop the medications because I had one problem, now I have another one, and am I better? Who knows? But 72% of people in surveys said they stopped taking bladder medications after 6 months, basically due to side effects. There are some advanced therapies on top of behavior modification and oral medication. And I want to spend a few minutes talking about these. These are things you probably have not heard of because most non-urologists are not very familiar with these options. And even if you see a urologist, I would say the majority of them don't talk about this either. I do. I think these are great therapies. I found them very, I love doing these procedures because it's so helpful. It's very, what's the word I'm looking for? When you're so satisfied by helping someone. You're satisfied.
That's
Okay. Before we go there, let's talk about some other medications. Botox. Botox has been around forever. You're all familiar with Botox in the cosmetic world and treating the wrinkles in the face. It is FDA approved for overactive bladder, for the bladder, which we do. This is a office-based procedure. We do 20 different injections into the bladder wall. This is a quick procedure. It's very easy to do. The downside is that it wears off in 6 months. So if you love it, you have to have 2 shots for the rest of your life. And so I find that half the patients quit doing it just because it sort of becomes labor intensive. But, it can be very helpful, and that's something we can certainly talk about. Moving on into these advanced treatments, which you've probably not heard of, is the Medtronic neurosystem. This is a posterior tibial neuromodulation. That's what this acronym stands for. And basically, this is getting back at that slide I showed you where the signal goes from the bladder or the rectum to the brain. Like I'm full, brain sends a signal back to the bladder or bowel. This is related to that. So in this system, we have a stimulator. This is done in the office. We have a small little, tiny little needle we put by your posterior tibial nerve. And so we give small little electrical stimulations that follow that posterior tibial nerve back to the spinal cord, goes up to the brain, and it basically interacts with that system. You have nerves that go from the bladder or bowel to the brain. And something about that system is telling the brain to tell the bladder and the bowel to be active. So it wants to get the muscles to start contracting. That's when a person gets an urgency to go to the bathroom. Sometimes you can hold it and prevent incontinence, but you're rushing to the bathroom to urinate, and sometimes you urinate on your way. So what this system does is it sends an impulse from the posterior tibial nerve to the spinal cord to the brain. And the way I think about this is that it bombards the system and it overloads, and it kind of it gets the brain so tied up with what's going on there. It's like the brain forgets to send the signal back to the bladder to tell it wants to contract. So it has a relaxing effect. And that's true of the bowel and the bladder. So another analogy, I don't know if you've ever heard of this, but if you're going to give someone a shot and someone, they're scared, they don't want to feel the needle, and you slap the arm, you're sending signals back to the brain. The brain feels that sensation of the slap. So the brain's being bombarded when you stick the needle in. It's like, hey, I didn't feel that. The brain's it's so busy interpreting the pain signal or the sensory signal that that needle signal gets lost. So I don't know if that helps you, but it's just that it bombards the sensory pathway so that relaxes the contraction pathway. This is done in the office. It does reduce urinary urgency, frequency, and incontinence. It's delivered doing 30-minute office sessions over 12 weeks. This can be very helpful. After that 12 weeks, we do recommend maintenance sessions. So very easy. I find this is more labor intensive. And I want to talk to you about this other system that is also very helpful. It's still neuromodulation. This is sacral neuromodulation. So the differences between the two is that this is done in the office, and we're sending signals around the posterior tibial nerve, which has to go to the spinal cord, to the brain to stop that contraction signal. On this one, wrong way. On this one, we're putting a small wire in your lower back. And I wish I had a picture showing the spinal cord. The spinal cord ends way above your waist between the first and second lumbar vertebrae, way up here. What we're doing is way down here by your sacrum. So we're probably about this far from your spinal cord. We're nowhere near that. And we simply, this is an in-office procedure. You lay on your stomach. This takes about 10 minutes to do. We put some numbing medicine in your lower back. We place a small little needle, just like if you're going to have blood drawn, and right under the skin. And we stimulate that wire, and we can tell by what you feel and what we see from the surrounding area if we're in the right place. And when we're in the right place, we drop a little wire through that needle, take the needle out, take that small wire to your back. And then you go home, and we hook that up to a small stimulator, and you immediately start avoiding diarrhea. So the difference between the two is the posterior tibial nerve is done in the office, 30-minute sessions over 12 weeks. This is done one time in the office. You go home, and we do this test over 2 or 3 days, and you complete avoiding diarrhea. So this is kind of one test so we can see if you're doing well. My experience with this is that you know immediately if it's going to help you. And it's a very easy test to do. We do it in the office. It almost immediately lets you know if it's going to work for you. If that test, this is what we call a test stimulation. If that works, then we come back and we put a small wire, which is a permanent wire, and we put this small little transmitter underneath your skin in your upper buttocks there. Very easy, as opposed to Botox. You have to have this twice a year for the rest of your life. This is one shot. We put it in, you go home, and your urgency and frequency, is improved. There's both rechargeable and rechargeable free. So we can, there are two different types. We can do a battery that you never have to mess with. The battery does at some point need to be changed. 5 years, 4 to 7 years, depends on how much stimulation you need. And there are some that we can put in there that you can recharge daily, every other day. It's strictly up to you. So the best way to get better from this is to say yes to the test. I talk to people about tests all the time. The beauty of it, it's done in the office. It's quick. And, for those of you who have been frustrated, tried other medicines, still not where you want to be, this is a no-brainer. We generally try medications first, unless you've tried it before, or you're allergic to it, or just can't tolerate side effects. But once we've done some of those initial therapies, you're still not where you want to be. This is a great option, and I encourage all of my patients to do this because it's very easy. 89%, it is safe and effective. 89% of people using the system experience long-term success. 76% of people achieve success with sacral neuromodulation compared to 49% for medications. Is this therapy right for you? I would say yes. If you're in a situation where you're not happy where you are right now, you have frequency urgency, urgent continence, anything in that spectrum there, then this therapy is right for you. Some people have had back procedures, back surgeries. Typically that's in the lumbar area. I've done this in people who've had back procedures before. And if you've tried other things and you're motivated to get better, this is a great option. Let's see, frequently asked questions. I do have some questions here. So how long does the release leaf last? Sacral nerve modulation has been shown to be effective up to 5 years. Your experience can be different. Will it cure my condition? It's a treatment. It doesn't cure it, but it controls it. I guess if you're leaking and you do something that makes you not leak, can you say it cures it? If you want to call it a cure, fine, but it's a treatment for it. What does a stimulation feel like? It is a pleasant, sort of vibratory sensation. It's not irritative. It's not annoying. You're not aware 24/7 that you have this. Yeah, if you stop and think about, okay, yeah, I can feel a little. It's kind of like breathing. You know, we breathe all day long. We don't think about it. It's just a part of, we breathe and we're not aware of it. This is how that is. It's just a very pleasant stimulation, not painful. Insurance does cover this, as does Medicare. Can I have an MRI? Yes, you can. These are MRI compatible devices. Do these treatment options apply to both men and women? That answer is yes. If I had the testing done, is this still good for the bowels? Yes, it is good for the bowels. I only have issues with an overactive bladder at night, so I never get a good night's sleep. What are your recommendations? We spend a lot of time trying to get people to sleep at night. I mean, it's one thing if you've got overactive symptoms during the day and you're awake. I mean, at night, we want to go to sleep and want to stay asleep all night so we feel rested. So my recommendations are, if you're having trouble sleeping at night, to come in. We kind of go through, we need to have the right diagnosis. Is this overactive bladder? Is it failure to empty? Is it volume overload? Some people have problems with congestive heart failure. If your legs are swelling, you're going to get up more at night. So we have to have the right diagnosis. Our recommendations are to see your doctor for sure. Can you have an InterStim if you have a spinal cord stimulator for back pain? That answer is yes. Do I prefer chargeable or non-chargeable? That's strictly up to the patient. The chargeable one is kind of a no-brainer. You don't have to mess with it. If you get to a point where it's working great and you start having problems, we check the battery. If the battery is dead, we make one small incision, take that out, hook up a new one, put it back in, you're good for another 5 years. So if you don't want to have to do that, and you like the idea of having a rechargeable, then you have to put a little band around your battery not every day, maybe every other day. So that's strictly up to you. Will it cause a urinary tract infection? No, it will not. Do most of your patients see good results from the test? Yes, they do. Most of the patients that have the test go on to have the implant. I can only think of a few cases where we didn't go on to implant because people do the test, they get better, they're so excited. Yes, they want the implant. So yes. Are you able to control the InterStim system once having the implant? Yes, we have little remote controllers that we can use to manipulate the device. I would say the majority of people get their device, they leave it alone, they do fine. If we find along the way that you're having a few hiccups, where we can troubleshoot the device, we can change the amount of intensity of the stimulation. We can do a lot of things to the device. So the answer is yes, we can communicate with the device and change it if we need to. What kind of complaints do you have from patients that have this therapy? What kind of complaints have I had during the past? The generator site was bothering them. That's a minor problem. That's an infrequent problem. What else? Some people can have more frequency of bowel movements. If you're having fecal incontinence, then it's great. It reduces that. If you had normal, like one bowel movement a day and you have interstim, you might have 2 bowel movements a day or 3 possibly. It doesn't cause fecal incontinence, but if you were completely normal with that, some people might go more often. I don't find that's a real frequent problem, but I've had that. What if I've tried Botox? Would interstim work on me? The answer is yes. You can do both of those. How big is the interstim device? It's about the size of, I guess, maybe 2/4. What is the test process like? You come into the office. We have you lay down on a table. We prep your back. We use a little X-ray arm so we can actually see your sacral bone. I didn't talk about this, but the procedure actually goes in through one of the openings in your sacral bone. Your sacral bone is shaped like a triangle. You have 4 openings in there. It's right underneath the skin. We inject a little medication. We use X-ray to find that little opening, and we put the needle right in that opening, drop a little wire out in that opening, remove the needle, take that to your back. So we do that very quickly in the office. Once we take it to your back, we hook that up to an external stimulator. You go home, you immediately start a voiding diary. We do a voiding diary before and after the neuromodulating procedures. We have to show insurances in both Medicare that you are 50% better after that for them to pay. Can you see the device under the skin? Most of the time, not. These are small devices. We go not right underneath the skin. We go about I don't know, a 1/2 inch underneath the skin. It's usually hidden. If you want to talk about getting the implant, what are the next steps? The next steps for you tonight are to, I think you'll have my number here. You can call here. You'll get an email tomorrow. If you'd like to have this discussion, you're not obligated to have the thing. If you want to come in, we can just talk about it. I can show you how it's done. We can talk in more detail. And I'm very optimistic that I can help you. So check your email inbox, respond to that, and someone will get back with you. Those are all the questions that I have right now. If there are any more, I'll certainly entertain them. I want to thank y'all for being with me tonight, and I hope you learned something. Kyle, anything else?
Hey, thanks, Dr. Roth.
I wish everyone a Merry Christmas too.
Yeah, no, you did a terrific job of explaining everything. And I really appreciate you taking the time to go into this in detail with everyone. On the screen here, you can see are a few bits of contact for Dr. Roth, his website and his phone number on the bottom there. And Dr. Roth's office will be following up with everyone. And I would encourage you to follow up with him as well if you're interested in potentially setting up a follow-up appointment with Dr. Roth. But no, I think you answered a lot of the good questions that came across, and did a great job explaining all the different treatment options to everyone. So I thought it was terrific. So thank you for going into detail on that. And if you'd like to close it out, Dr. Roth, go ahead and just.
Yeah. I want to wish everyone a Merry Christmas. I hope you picked up on something tonight. I mean, the take-home message tonight is that you have overactive bladder, and this is affecting your quality of life. Absolutely come in. You're not coming in to get a procedure. You're just coming in for a talk. They're like I said, I went through a lot of these things, but just brush the surface. If you want to have a conversation, come on in. I'm optimistic I can help you. And let's get your quality of life. New year, New Year's resolution, get control of your bladder and your bowel. So come in, let's talk about it.
Thank you, everyone, for joining us, for taking your time. And this will conclude our program. Have a wonderful night and Merry Christmas.